three focal areas. Shh. Silence. So we had done three different areas. So now a global approach for the patient. So patient will be over there and we will project this patient on the screen also. So here comes the, do you want to?
Yeah, but have small things just to start.
Okay.
To warm up and then we'll go.
Yes.
Okay.
Start.
Perfect. Well, thank you very much. It's always difficult to talk after such talent on stage. Me and Rami are trying to get the best out of it.
Yep.
I'm joking with Rami all day, so if you want to take pictures with him, you have to go from here because I'm the booker.
Thank you very much. It's always a pleasure to be here in Pakistan, guys. Thank you for having us. Hopefully this will be as fun for us as it is for you.
So our idea, that was the challenge today, is how we assess the face and how we plan the treatment. And what sometimes we think about cosmetics as an art, I think it's science that can guide you. It's not just something that comes out of our extraordinary skills in terms of artistry. So we need to have something on. Can we have the thing on? And, well, let me take the chair for a moment out of this. And things we talked about is that we are actually looking into beauty. And this is actually published in the Plastic Reconstructive Surgery Journal. And beauty is much more than what we are able to offer. Beauty involves all the five senses. And on top of that, depends on which part of the world you live, depends on your culture, depends on your religion values, depends on a lot of things. What we are working with is with this, is with attractiveness, which is a visual sense. It's something that you look and is attractive or is not. And someone is attractive in Japan, is attractive in the deep Amazonian jungle because that has the characteristics and the particularities of the face are there. So we are working on this. And this is something that varies. This lady, she was a brand manager for a cosmetic company, and she was moved from UK to South Korea. And the first thing she noticed is the way women actually use makeup is different. And that changes completely the colors, the highlights, the shadows, the eyelashes, which are in the far wrist, are actually longer in the middle, not on the side, etc. And I felt this on my practice the first time I went for a course, to give a course in South Korea, that the things that I used to do...
We're going to pause you.
There is a lot of noise in the background. The speakers are getting disturbed. Please be attentive. These guys have come from so far away to deliver you their talks. So please give them respect. And I would request you to just pay a little attention here to the stage. And if you guys are going to talk, then you can go outside. So thank you very much.
Thank you.
Thank you.
So this changes the way we see things. And we are both based in Dubai, and what we have is a multicultural type of environment. And so that's what we have to address on a daily basis. Rami.
Yeah, I mean, when a patient comes in, it's not what you see. Beauty is in the eye of the beholder. It's not always what you wish. We have to ask the patient what they want. So a lot contributes in the treatment planning. For example, if I have a bride and she's getting married in a couple of days, this is a patient I wouldn't do anything to because time is an important element. Patient's budget is an important element. And then this part where I'm going to say, if a patient can afford 2 cc's and you think the patient needs 4 cc's, never compromise to 2 cc's. Find a way because the patient will never be happy. As far as age, we can't make a 40-year-old look like a 20-year-old. What we can do is make a 40-year-old look like a healthy 40-year-old, and that's our goal. So we have to be very realistic. Patient's lifestyle, I wouldn't go filling someone who's a marathon or a triathlon runner because I'll think of alternatives. I wouldn't do hyaluronic acid, I would think of a collagen stimulator. So patient assessment is very important. Now, I'm sure you've all attended a lot of conferences, and there has been loads and loads and loads of ways of how to assess the face. The golden ratio, the 1 to 1.6, the 3/3, the 5/5. And it depends on how you look at it. And I know there are some devices now out. But in all honesty, what I find is, just like what Dr. DeMello was speaking earlier, the way I would treat a face in Korea is different than the way I would treat a face, the same face, in Europe, because their wishes are different. Are you aware of a furniture shop called IKEA? Okay. So IKEA, if you buy a chest of drawers from IKEA, whether you buy it in the States, Europe, Asia, you fix it exactly the same. Unfortunately, the face is no IKEA. You can't IKEA the face. So it depends from one place to another. We have to respect anatomy. We have to respect the layers. We need to understand, there are plenty of names of what we do. My favorite is anti-aging. They called it aesthetic medicine, minimally invasive surgery. But because what we're trying to do is, and in order to do what we want to do in the right way, we need to understand aging. We need to respect the anatomical landmark. When the business of injectables first started happening, I remember the first course I took, they asked me to do a nasolabial. And I went in, and the best way to treat the nasolabial 15 years ago was to inject the nasolabial. Slowly we realized, one, that's anatomically dangerous. Two, the nasolabial is not caused only by the aging of the mid-face. It's all caused by the aging of the upper face. So in order to treat it in the right way, we need to understand what caused it. We need to understand the anatomical layers. We need to know which fat pads move and which fat pads stay exactly the same. Because if you inject the wrong fat pad, a fat pad that has the tendency of inferior migration, then you're sorting a problem by causing another problem. So now, and you'll see slowly how conferences moved, aesthetic conferences moved from talking about techniques to slowly talking about complications to later on talking about anatomy, because this is what we need to understand fully. We need to understand the aging process as well. What happens, where it happens, what happens to the bone, what happens to the muscles, what happens to the muscular activity with time. Is it the superficial or the deep fat pads I'm trying to address? And accordingly, we decide how to treatment plan the patient. There is plenty of ways of how to be a safe injector. A lot of books that have talked about anatomical landmarks. What I could assure you, with my very modest experience, that anatomy varies. And there's no such thing as making sure that, oh, I'm going to be safe here. Because this is how the vasculature of the face is. So rather than, yes, respect the anatomy, we need to think of the technique. And if you want me to sum it up, inject slowly. Be very careful. Because it does vary.
Well, and if you are brave enough to prick a needle through this, then you are in the right place. Because this is the tricky part. And the face, as we chose, is about layers. It's like an onion. It's not about which layers you are injecting. It's about which layers you need to cross to place your filler at the right level. But we all went to med school. Some of us longer than others. Some of us more, well, ages ago, like me. But the first thing they teach you in anatomy class is variation. And this is the variations of the facial artery. And actually, the nasal type is the most common one, not the angular type. And sometimes I'm so worried about the angular artery, it doesn't even exist. And sometimes it exists in one side, it might not exist on the other side. Because not only anatomy varies from person to person, it varies from side to side. Because the origin, the embryology is different. So what we need to be sure is that you know where your devices are, and you are treating the patient according to a treatment plan, and that's what we're trying to get it here. People, when we start talking about anatomy in conferences, and I remember, well, the first few years of IMCAS in Paris, It was only about injecting, 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 needles, needles, needles. Well, I finished residency when Restylane launched the first product. It was in '96. They came to me, said, please, can you use this or try to use this? I said, for what? Just finished plastic surgery, why should I going to do this? Oh, for lips and nasolabial folds. And that's what we are doing. And we don't care about vascular complications, we don't care about migration, we don't care about anything. And the truth is, it's a very safe treatment. Because if it was not such a safe treatment, you're not doing it. But now it's all about the complications, and then you start speaking about danger zones. Well, the face is a danger zone. But the biggest danger is not the face or the product, is the physician, or is the person who's injecting. Is his knowledge and ability. And that's what we're trying to get it now. And we're going to get the patient, a model here, not the patient. Hopefully tomorrow we can show what you're going to do. And let's have some assessment. So me and Rami are going to look at this person. We have more than one. We're going to engage with you, asking you to also come up with ideas and what you think you're going to do. And we're going to mark, because we do more or less the same thing, all of us here, but we do it differently. And those so small nuances that sometimes can improve, and that's why you're learning from each other, because I want to learn from you today also. So,
So we get, do we have someone to treatment plan?
Okay. Yes, there was one patient for you. You need both male and female
No, let's get a
simultaneously,
female
or
first.
one
Yes.
by one?
let's give a man a chance for the first time.
So we also decided that male aesthetics are a new upcoming field, and more male patients are coming for aesthetic treatments. So we decided that we must have
Gonna ask
a
Sam.
male patient for the assessment first and then a female patient. Because what happens most of the times, what we do, we do feminization of male patients. So this will teach you
Which
how
camera?
to do the fillers, threads,
Yes, the
and
camera over
botulinum
there.
toxin
Can I change it
in
again?
male patients.
Yeah, because the camera will be that one. This is the camera, right? Yeah, so.
ये स्क्रीन पर डिस्प्ले करना है, कहाँ गया भैया? स्क्रीन पे लाना ही है.
Can we have it on the big screen on Zoom, please, on the face? Your name is? Dr. Safras, thank you very much.
अच्छा, एक और बात जो है ना, very important, कि एनाटॉमी की जितनी क्लिनिकल वेरिएशंस एशियंस में है, उतनी और कहीं नहीं है. I tell you that you read a lot all about facial artery, but one day you will prick and you will come to know that, oh my God, it was not supposed to be here, and this artery is here. Why? Because maximum anatomical variations you can see is in our population, Asians.
Brilliant. So,
You go first.
okay. So this gentleman comes in to my clinic. This is what I would do. The first thing I would, rather than jumping into conclusions and going, this is what you need to do, this is what you need to do, always ask the patient first, what is troubling them? Because I'm very known for saying no in my clinic, no in my practice. Rather than just throwing treatments at your patient, check what your patient is complaining of and accordingly decide. Because just because you see that the patient needs tear trough doesn't mean that the patient needs tear trough or is bothered by it. Let's always remember we're not doing open heart surgery here. Everything we do is what a patient wants, it's not what a patient needs. So what's bothering you, sir, young man? Nothing is bothering you.
Thank you
Perfect,
very
let's
much.
take
Have a
wrap.
great day.
Perfect. Play with us. Under eye. Sagging of your cheeks. Okay. And so the gentleman is complaining of under eyes and sagging of the cheek. I'm going to talk about the under eyes and I'm going to let you talk. Is that all right?
Yeah.
Right. When it comes to under eye tear trough, there are three causes of tear trough. Cause number one, loss of volume. When someone tells me a tear trough or is complaining of a tear trough, it means that there's darkness under the eyes. So it could be either loss of volume under the eyes. Option B is pigmentation. So there's no loss of volume, but it's pigmented. Option C is a bit of both, right? Now, there's under eye and there is eye bags. Eye bags is completely different complaint that has nothing to do with minimally invasive surgeries. It means that the deep fat is going through the orbicularis oculi muscle, and it's not treated with hyaluronic acid, with fillers. So let's go back to our first thing. So it's either caused by loss of volume or skin pigmentation or a bit of both. Fillers comes in very handy when we have loss of volume. And personally, I would choose something that is very flowy, but I would inject always under the muscle and never over the muscle to avoid Tyndall effect. What are your thoughts?
Well, my thoughts is definitely that can be done, but the first thing I look is the patient's face as a whole. And I want to see essentially two proportions, the width and the height. Someone who has a long face, like our nice, good patient, I don't want to get it more longer, unless he's looking to look more slimmer. If it is wider, I cannot go wider, otherwise that unbalance is a bit uncomfortable for people. Because the first thing we look into patient's face is not actually the glabella or the lips, is the shape. And the shape tells you the gender, the age, and if they are healthy or not. Then you go to the glabella. Kids go to the glabella immediately, because if someone is frowning, they don't get close to you. They stay away. But the lips comes on the end of it. But if I want to improve the shape, so the shape is okay. I don't need to go there. Then we go on symmetry. There's always one side which has more volume than the other. Again, I totally agree with Dr. Jamil saying you don't need to bring people to perfect symmetry, but you need to approximate the symmetry somehow. What you cannot do is change the symmetry. Because if one side is less than the other and then you swap it, that will be becoming uncomfortable, because not just for pictures, when we see ourselves in the mirror, we see ourselves different. And then we go into details. The upper third is long, the mid third, the lower third, all of them are very well balanced. And when all the big things are balanced, we go for the details. When we talk about teardrop and dark circles, those are things that we tend to put in one package, and they're actually different. Dark circles usually is because of pigmentation. Dark circles can be constitutional. Dark circles can be acquired. The teardrop is usually related to volume loss. That's why you use it for treatments. And it's this combination that you can bring it at teardrop and dark circles, because most of the times they are simultaneous. They exist in the same condition. We can improve them both. And I totally agree with you. I think we can definitely improve, and by improving the mid-malar area, we can bring that signs of aging better, more balanced, and at the same time, you can have a bit of a pull over the nasolabial folds. And that improves my cheeks. That's why I want to get to the cheeks, because the cheeks were mine. And the thing is, and the cheek is a very broad term in terms of medicine. Cheeks can go from the nose to the ears, but then extends where to the commissure down. It's a big area. So it's the mid-malar area, it's the zygomatic arch, it's the submalar, because we have names for those things. And that's what we need to treat.
Yeah, and then we can't ignore the fact that the cheeks or the nasolabial are not the result only of the mid-face aging, are the result of the upper face aging as well. So in order to treat the face fully, you need to start off in a systemic way, where you go upward, downward, inside, out, deep, superficial. So this is the process planning that you need to do. Upward, downward, outward, inside, deep, superficial.
And there's another thing that we're talking about, that you talk very, very nicely, is about the fat pads. The superficial fat is not related to aging. Superficial fat is related to weight. That's why my face is full, I'm overweight. So my deep fat is suffering atrophy. You can see around my eyes. Because if you see a picture of me 10 years younger, my mid-face will be fuller, and the lower face has not as much. But this superficial fat slides. And slides where? The nasolabial fat pads and the jowl fat pads. And that is not for us to fill. So that's why we probably have to combine things with what we use for threads. or being a surgeon with a facelift, because that's what we're doing, volume reposition, not just volume replacement. It's a combination of both. And in men, sometimes, that is more important than replacement.
100%. So there's a saying that says, if you got a hammer, not everything is a nail. If you only want to, don't look at the face and think, I'm only going to use one treatment. Again, this is something that started changing with time, because combination treatment is the way forward now. Try combining. Understanding the anatomy, understanding the fat pads will make you realize that why not do a bit of botulinum toxin to relax the muscles, a bit of fillers to replace the volume, and some threads to restore and reposition the fat pads.
And so, if you want to draw on the face, let's say for fillers, what will be the areas that you draw?
Well, he complained.
Do you have any other suggestions?
Yes, please suggest.
Now is the right time to say something. Sometimes just saying, I don't treat him, let's go home. Simple as that.
Yeah. Don't listen to Rami. He will never say no to patient in his clinic. But over here, yes. Yes, please.
Any suggestions on how you would treat a patient, or any queries, or anything you want us to address specifically?
So one at a time, sorry. Ladies first. Okay, please.
Quality of the skin, absolutely. And therefore, how awesome would it be if you have a product that doesn't only replace volume, but improves skin quality?
Can go around with the microphone, yes, please. How do you set the symmetry? Okay, the symmetry, that's a very good question, a very good point, because symmetry is not just depending on volume, it also depends on expression. And sometimes you have one brow that goes higher than the other. Sometimes, well, on the upper third is easy. The lower, mid-third and lower third is much more difficult to correct symmetry with neurotoxins.
Because of the muscle activity in the front of the face. So obviously we're going to be deflating those muscles first, and then we're going to go ahead and work upon their symmetry with the fillers, right? That's
Definitely.
the approach, yeah.
I have one step that I usually try to find is have someone with a big masseter.
That's right.
Or someone with bruxism, for instance, very wide masseters. I will not treat the mid-face without getting those masseters treated with neurotoxin first, because just that can give me the oval back again. And not only that, then you're becoming very useful because you're also treating a functional problem also, not just a cosmetic one. So it's two in one, it's perfect.
Yeah, that's right.
Can we have 1 minute break because
Yeah,
our friend has to go.
okay.
We have to presentation.
Please, take your time.
So please, a big hand for Dr. Patrick Reddy. So big hand.
Can I have the lady out?
Thank you.
Okay.
Thank you. Start.
You can ask the audience if they have any questions. How they start first.
How do they start first? Okay. What would you start with, guys? How would you, if this gentleman came to your clinic, how would you start? What's your first step? What would you do? Mesotherapy.
For what? Okay.
Dr. Madhiya, yes. So she is going for the volume loss and for the jawline,
Okay.
sag. And you please?
So I would like to know first what exactly is it that you do? Because obviously I can see that there are a lot of things that can be done, but at the end of the day,
I hope your ego is good. Huh? self-confidence.
necessarily need to look like a model. You know, you don't have to walk the runway. So we need to keep in mind.
Option, treatment option.
So treatment options. So I can definitely see that his lateral brows. You can do so much with some pencil filling. There's the cheeks, the open curve, the cheeks. They need some support. And the under eye, I just learned that great technique today. Not just doing it low, just lifting the middle cheek also, along with the teardrop, and doing the Mirmon fossa in order to get lifted overall.
So you think that lifting of the little eyebrows and some volume in the teardrop,
Volume in the teardrop and volume in the mid cheek.
volume in the mid cheek.
So replacing the volume or addressing the volume, because sometimes you don't only have to add volume, sometimes it's important to remove volume. But he said something about the eyebrows, which is quite cool, which is where you'll see this is the few things that me and Francesco disagree on, where how to inject the temple fossa, how to inject the temple area. To start off, show me hands who inject temporal fossas in the audience.
Raise your hands.
Only that? No.
Only that? Okay.
Come on, don't be shy.
Right, so my second question is, who injects superficially?
What is superficial?
Over the muscle.
Oh, sometimes, why not?
Who injects on bone? See, that's why I love Pakistan. This
Why?
is where the debate is. And it's one of the most debatable subjects that I've seen in every single conference I've attended.
No, when we both attended.
Yeah.
When we both attend the same conference. Should we inject over the muscle or should we inject under the muscle? Let's
I don't inject over the muscle. I inject between the superficial and the deep temporal fascia.
But
which
how
has
can you
two-
know that you're in the right space?
Oh, it's simple. We feel it. You know it.
Yeah,
Yeah.
it's very simple.
Is it simple though?
Yeah.
So do you know what's the safe zone over the muscle? What is the safe zone to inject your filler
You want to
over the
show
muscle?
you want to show your thing? And then I show mine.
Yeah.
Okay? So I'm a big fan of injecting deep on bone because I find it's safer. There's no as such as safe, but it's safer for me to go straight onto bone at a certain point. I find that temporal fossa works like a swimming pool where there's a shallow part and the deep part. If I find the most shallow part and inject it over the superficial temporal fossa,
Can you got the
on the
screen?
supraperiosteal,
Can you got
then
the screen?
that does the job for me. And for that, oh,
It's coming here.
sorry. So for that, anyone who has attended any of my talks, it's quite simple to find it because I start off by taking 1 centimeter lateral from the lateral orbital margin at the lateral canthus. From there, and then I draw the temporal crest. I draw a line between them. At that point, I go straight 1 centimeter inferior to the temporal crest. I go straight onto bone, and I give my bolus, which is called, in other words, the shotgun technique. This is where exactly it is. And I find that, in a way, maybe because I'm used to it, maybe just because I want to annoy Francesco every once in a while, that's how I inject it, and I inject my material straight onto bone as a gunshot. And with that, you end up with raising the eyebrow a little bit, but you have to do a little bit of botulinum toxin to relax the orbicularis oculi. A quick video showing where I'm drawing it. Let me try and fast forward this quickly. So this is the straight line, 1 centimeter lateral to the canthus. I've drawn the temporal crest. Even though I know I'm in a safe-ish area, I still palpate to make sure that I'm not over the temporal, superficial temporal artery. And it's very easy to find the superficial temporal artery. If you can't feel it, you can ask your patient to open and close their mouth very quickly, and that artery will start palpating. And then I go, oops, sorry. I go straight onto bone, hitting the supraperiosteal, I aspirate, and it's all about injecting very, 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 very slowly in that area.
So you are a fan of needle in this area?
I'm a big fan of the needle just because I don't know how to get to the right plane if I'm going to inject over the muscle. However, Francesco has a fantastic, cool way of doing it.
Yes.
I just have one comment about neurotoxins for elevate the brow in men. Make sure people, they want the elevation of the brow, because usually men don't have much of lateral elevation, because they have a bit of a sign of feminization sometimes. Well, I used to do that, but there's one area that I'm not comfortable doing with a needle, is when you get closer to the zygomatic arch. Because not only your needle doesn't reach the bone, we have the sentinel vein, and there's an artery that is anastomosis to the internal carotid system, and sometimes you get lost there. And I used to do, this was, well, a long time ago, with very thick fillers in the area, and sometimes they show up in the midface because they just go along the temporalis muscle and they show in the maxilla fossa. So what I do is slightly different. I like to come from there. You can come from the crest, the temporal crest, you can come from the zygomatic arch, but from there, you just land. There's almost no subcutaneous fat. You got the superficial temporal fascia, and you have a natural space, which is what the natural fat pad of the temporal area is between both fascias. And I did a small surgery. I was doing a temporal lift recently, and I just got this video. And you can see there's the subcutaneous tissue, there's the superficial temporal fascia, and I'm in that space where I want to place my filler. It's very thick. So if you go with the cannula, gets underneath, and then it just slides in. And here, on top of it, is the superficial temporal artery. So deep to the bone is safe. Under the superficial temporal fascia is safe. Subcutaneous is the most unsafe and most dangerous place to be in the temporal area. So
I think that's a good idea.
Stay away from
I
it.
think that you can glide in easily. And with it, I think 22 gauge cannula, you can reach.
Yep.
And let me show you quickly how I do it. Sorry. So get the cannula, small lines. People say, oh, what about the hair? Put some sterile gauze, clean it. Entry point away from the superficial temporal artery, 22 gauge cannula, just drill it, there I am. As simple as that. And it's painless because there's nothing in there except close to the orbit, we have the temporal branch, the frontal branch of the facial nerve, but you are with a cannula. And from that point, you can actually drill to the tail of the brow and place a little bit of filler and get that result.
And I think you need less material to augment when you go
Much less.
more superficial, yeah.
So let's go back.
Yes. So, if we look at this gentleman, you
Sure.
can see that his eyebrows are
Can
quite...
you go on the camera again, please?
Camera, please. So, what we can do to raise? Because when you look at his face, the first thing is that how to raise his
I think
brows.
it needs a full raise of the brows. This will be neurotoxin eventually, because there's not really a temporal loss of volume. And if you get more volume on the temporal when there's no need, just get a very broad forehead and temporal
Yeah.
areas. You look like you come from Mars,
Yeah.
right? You don't need that.
Yeah.
So, what's your opinion? What you are going to do?
If I'm stuck with a minimally invasive procedure and I'm not allowed to take this gentleman to the OR, I would start off by doing botulinum toxin to relax the orbicularis oculi muscle.
Yeah.
After doing the orbicularis oculi, after doing that, I would replace the volume loss if there's any volume loss. And then finally, I would go, if still needed, and it's the least of my favorite treatments when it comes to threads, I would consider using Silhouette Soft in order to raise the eyebrows.
Okay. And if you are talking again and again about the volume, so where you are going to put your volume and how many mLs on one side?
Well, I mark it.
Yes.
The only way for me to know how much, I have to draw it. Without a pen, I don't know how to guess things. So honestly, on the mid face, I think definitely the mid-malar area you can have a little bit. So this is the orbital rim. Can you relax completely? The upper level of the nasal fat pads. I have a little bit of a malar mold here. This is where I need to fill. Definitely, this will be the area that I'll get my filler. And if I have to choose, I would choose LNC for this occasion.
Okay.
Because he's a man, we don't like to be pricked. We like subtle, progressive results. And this not only gets that, but going to last long. And that's what I need. And skin laxity will improve with the biostimulation. So it'll be more than one thing I get there. And at this level in red, I'll go supraperiosteal. Below, I'll go subcutaneous. Supraperiosteal to the piriform aperture. And this will improve me completely the mid-face. I don't think I need to go over the zygomatic arch, but because that will bring feminization to a man's face. So I'll stay out of it. And when you go down into the jowl, to the jawline, eventually I'll get some small bolus over the angle of the mandible because there's some level of bone atrophy in the area, and I need to get that chiseled and more pronounced jawline in terms of definition. And honestly, with fillers, that's what I do. Start with this. Because I'm using LNC, 2 months after, I'll come with Silhouette Soft, mainly for the mid-face, to get the volume reposition over the nasolabial fold, because this will not be able to correct the nasal fold as I would like to. So I stage the treatment in two parts. First, volume reposition. Second, volume replacement. Second, volume reposition. And I will probably not address the lower face because the lower face is quite good. There's harmony on that. This is the mid face, which is not in harmony with the rest.
So you are going to inject 2 ml of LNC?
No, I will inject probably 1 ml per
1
side.
ml per side.
Per side.
So less volume.
But he mentioned something really interesting, which is marking. Now, there are a few places when you want to mark in the face that are static. For example, the nose. I just mark it the way I see the patient. However, the cheeks, the lips, when you want to mark it, you need to mark the patient when the patient is stable and when the patient is moving. Because just like what Francesco did, he marked the triangle. And if I look at the patient from a 45 degrees, I would think, you know what, this whole area has volume loss. But when the patient smiles, can you smile for me, sir? You'll find that the inferior part of your marking of that triangle is full when the patient smiles. But the upper part is not full, and that's why we need to mark where both areas meet in order to inject. And if you remember when fillers first started coming in, you see those Hollywood actors and actresses on the red carpet, whenever they'd smile, everything would jump in and their eyes would go closer. Slowly they realized the assessment is different now. You have to assess the patient, yes, when the patient's stable, and then when the patient moves and smiles, then see where they both meet and where there's both volume loss, and then fill it. Just because you have a hammer, not everything is a nail. Just don't go start just filling, just because this is the only option. Sometimes we need to understand to say, no, we're not going to inject anymore. We don't want to overfill the face.
Yeah, I think that tomorrow we also discuss this point, that we always assess the patient for the Botox at rest as well as during forceful contraction or dynamically.
Yeah.
But I think for the fillers, it's the same. You have to assess the patient both at rest as well as dynamically to see the full expression, as very well said by you, that ask the patient, and you are doing the assessment while you are talking to the patient.
Yeah.
I think that's...
But that's why we smile for pictures.
Yeah.
The volume goes up. It looks happier. That's why you do that. If you don't have volume, you can smile as much as you can. You always look dreadful.
And one more thing, that in male patients, in the media you can see that lot of injections in the chin. So what do you think about this gentleman?
Say that again, sorry?
Chin?
In
The
social
chin.
media, Insta, you can see lot of doctors, they are doing injections in the chin in the male patients.
In the chin in the male patients?
Yeah.
Yeah.
To create a jawline, they show it that it's the best thing to create a jawline.
Yeah. I think to start off, if you asked me this question 10 years ago, I would have told you the male patient has to have a square chin, female patient has to have a pointy chin. Today, I ask my patients, what do they want?
Yeah.
Because some patients wanted pointy and others wanted square. So it all depends, it's very subjective to what the patients, what they're thinking. Some of them are happy with their chin. Again, I refuse to think there's a right and wrong when it comes to what we do, as far as where the material needs to be placed, because it's very subjective. I've had patients who come in, for example, asking to look plastic, male patients. And I have female patients coming in, they want to look very natural, just with a little bit of touch-ups. So it all depends on the patient's wishes.
There's one word I'm extremely afraid of, is natural. Because natural has so different meanings. I have patients coming asking for breast augmentation. I want a natural result. Then they show me a picture, and that is nothing natural at all, where I come from. The same thing happens with the face. Chin is a tendency now. Everyone wants to do chin. But the thing is, I'm doing workshops and trainings for a long, long time. Initially, everyone wants to do nasolabial folds and lips. Now, when they look to a patient, you need to do temples, you need to do chin, and it jumps like this because that's the tendency, that's the trend. And that's what you want to learn so you can offer to your patients. But more than that is looking to someone's face and see what fits there, what's going to look good, and if this, am I able to deliver what the patient is requesting? Because if I'm not, I just stop there, and I do mesotherapy. Can you have a lady now?
Yeah.
Can you have a female patient now?
Female patient. One last question. That how you are going to fix the jawline of this gentleman? He said that he is going with the fillers. What you are going to do?
Do you want me to talk about Silhouette Soft, don't you?
Yes, of course. Of course. Marianne?
So,
Yes?
the Silhouette Soft threads, and we're going to talk about it tomorrow, it's a repositioning thread. When we talk about the lower third, it is combined with the neck. Especially when patients come in with a little bit of saggy neck, you can't approach it and treat it without approaching the lower third. If we had a mole, if a patient had a mole at the age of 29, at the border of his mandible, by the age of 50, that mole is going to move under the neck, under the jawline. So therefore, we need to address the repositioning of it by lifting and lifting. So upward and backward, because the aging vector line goes downward and forward. And unfortunately, when it comes to threads, we choose the most mobile vector line. It's not up to us to go, right, this is what I want, this is what I... No, you choose the most part that has sagging, where it allows me to reposition, and accordingly, I draw my vector line for my thread treatment.
So you are going to use Silhouette in this patient?
If this gentleman came to my clinic, I'll be doing definitely a combination treatment.
Combination.
So I
As he said, what's your preference?
I would
First
start
is-
off with volume restoring. So I would start off by placing volume. Because let's put it this way, once we place volume up there, you're asking your threads to do less force because you've already started repositioning up. So I would start off definitely with restoring the volume, and then I would place my sutures.
I always have the example, if you have a pillow that is understuffed, you can stretch it, but it will always be wrinkled. So you need to stuff it first and then tighten it.
Yeah.
So that's how the face goes. You need to place the volume and then reposition, because if it's not there, you cannot reposition it.
Yeah.
If I do it in the same sitting, I prefer not to. I would prefer for the fillers to settle. However, we live in a very fast-paced life at the moment, and everyone wants everything now. So sometimes in my practice, I would make exceptions where if I am to store volume, I would store the upper volume and I would do sutures at the same time. That's it. That's the only place I would compromise.
But I'll compromise that, doing this first, doing the volume on the mid-face and thread and the silhouette soft on the lower face.
Yes.
Not volume on the mid-face and silhouette on the mid-face.
Yes.
Different areas.
Different
That's
areas.
okay.
That's very important. You have to learn that if you have to do two treatments, then you should set apart. do voluminization first and then repositioning later on.
Yes.
And if you have to do two things, then choose two different areas, not the same areas. So,
The question is,
yes,
which double chin?
this double chin.
Grow a beard. See? Covers everything.
So, where is our second patient? Thank you. Thank you very much.
Thank
A
you.
big hand for the first male patient.
Thank you.
Thank you very much.
Well, for the double chin, I think that's a good question is, we don't do usually threads if there's volume. We have to reduce the volume.
Yes.
And you can reduce the volume with the technology or with the techniques that you are used to. Lipolytic agents, energy devices, liposuction. You know,
There is this young girl. She wants what you can do for her.
Full facials, okay. All right.
Okay.
Maybe we could do that tomorrow once we
Yeah, we will do it tomorrow.
yes.
Yeah?
Yeah.
We'll be
Yeah,
here.
yeah.
We won't be going anywhere.
I will be here until the... Thank you. Okay, different face, different gender. Different requests, I'm sure. What is your main areas of concern? So the perioral area and eyes, the forehead. Okay. Have you done any treatment before? So cosmetic naive when it comes to that. Perfect. You want me to go? You go first? Go
No,
ahead.
no, go for
no,
it.
No, you go first. No, let's do the opposite. They go first now.
They go first. Okay, what will you guys do?
हाँ भाई. Yes, shabash. Nasolabial fold and with the volume, lips with the volume, and temples with the volume. So they are copycats.
Side profile. There we go.
Chin is fine. Is the face wider or longer? Can you look to the front now, please? Wider or longer? Yes, because actually you have a problem with the screen. In the screen, everybody gets wider. Look at me. The screen, everybody gets wider. No, it's just the screen. The thing is, you got a nice volume over your mid-malar area. The zygomatic arch lost some projection, so that's why I want to get a bit of oval there, definitely. The jawline looks quite good. Skin is very good. Around the eyes, I don't see much of volume loss. It's more about darkness. It's more about skin pigmentation. I don't see much of volume loss. I do see, because of the good volume you have on your mid-face, is sliding. For me, this is a candidate to get volume over the zygomatic arch, to get silhouette soft for the mid-face, to reposition that volume. And definitely lips. Always I have always a question. If I have the chance of doing only one treatment to this person, where I'm going to put all my money in the investment of the treatment, lips.
Lips.
Because that's the cheapest transformation you can have,
Yes.
and the most rewarding one.
Yes.
In order to simplify it, when you got a male and a female patient, the outline for the male, your job or the objective is having a square outline of the face. For the female, you want it oval. And that's why Francesco wanted to fill in here. By filling the zygoma area, you're widening that oval, that egg-shaped looked outline in order to feminize it and change it from a square face outline to an oval outline.
Do you grind your teeth? Do you grind your teeth? The grind. Can you clench, please? Can you clench? No. There's no hypertrophy of the masseters. I was trying to see if there's anything else you can do there.
This is very, very important thing. Whenever a patient enters your clinic, ask yourself one question. If I have to do one single treatment, what will be the best treatment option for the patient? Before discussing it, make up your mind and then discuss. I think that in this patient, this was the single best and the cheapest investment.
if
And
I-
what about you, sir?
I would agree with you. I would definitely focus on her lips in her case. Because if this is the only one thing I had to do, I get to do.
And if patient is willing that I can spend more, then one more thing, what you will add?
I would add Silhouette Soft in order to reduce that tissue reposition downwards, just to raise it a little bit.
Yes.
That's what I would
So
do.
what's your idea? Do you agree with this? Yes. So we are getting wiser and wiser.
And
Brilliant.
neurotoxin for the forehead because the patient mentioned it. And there's that small asymmetry on the position of the brows. They go quite down in the middle. I think, can you frown?
Sorry?
Can you
Frown.
frown?
Look
Good second.
angry.
Look like this. Essentially, if the corrugators are quite strong, definitely this needs to be balanced. The eyebrows actually, they have a nice arch. They just need to be raised more in the middle than on the lateral part, which is something also you don't see much often.
Yep.
So if in a very small amount or very low budget, we can do lips as well as a little bit of toxins. And
You know the funny thing about fillers, toxins, and threads is you don't need to do everything in one go.
yeah,
So the budget is going to be split in installments over a certain amount of time.
Yeah.
So we start, neurotoxins is great to build up confidence with the patient. Then we move to fillers. They're always a bit afraid of threads because they feel it's more invasive. And I always tell everyone it's the most safest treatment you can have.
Yeah.
Because the worst case scenario just doesn't work, but it doesn't create any damage. So that's the thing, straightforward for me. It's a plan, a price in front of his session, and the patient decide if they can afford or not.
I think that's the best idea. Start with the toxin and make a rapport with the patient. Patient will gain some confidence, or you can start with the lip, and then you can convince the patient for the repositioning.
And skincare.
And
because-
skincare.
And skincare.
We always forget about skin cares.
And
So
we're going to be
time-
kicked out. Okay.
Brilliant.
Yeah.
Well, thank you very much.
Thank
you
you.
very much.
Thank you
Thank
very
you.
much.